Good morning everyone. Today we will discuss about OCT biomarkers in diabetic macular edema. So, first of all, to classify diabetic macular edema, what is diabetic macular edema? So what is diabetic macular edema and what is the recent classification of diabetic macular edema? So, we are basing on our treatment plan. So, Dr. Nishna, can you elaborate what is the recent classification of diabetic macular edema? On which basis we are classifying diabetic macular edema? This answer is this local.
When the center subfield thickness is involving the 1 mm zone, according to the AD study, central 1 mm zone is involving edema is the central diabetic edema.
So, as I pointed out by Dr. Nishna, so the center involving diabetic macular edema and non-center involving diabetic macular edema. So, when the macular edema involves the center, it is like the 1 mm zone. As per the ADRS grid, 1 mm means the 1000 micron zone. It is the center involving diabetic macular edema. And the non-center one is which does not involve the 1000 micron zone. It is the non-center involving diabetic macular edema. So, center involving and non-center involving are important because center involving diabetic macular edema we have to treat with anti-VEGF or with steroids which are not responding to anti-VEGF treatment. Non-center involving macular edema we do a fluorescein angiography and can do a focal laser if needed. So, why the need for biomarkers? So, Dr. Anuj, what are biomarkers and why the need for biomarkers?
So, basically, the biomarkers are the conventional indicators which help us to diagnose the disease, monitor the response to treatment, and predict the prognosis of a disease.
Thank you, Dr. Anuj. Very good. And the biomarker, as Dr. Anuj said, it is a predictive response to the therapy. So it helps to identify that which the anti-VEGF or steroids, which are the good response to therapy with anti-VEGF or intravitreal steroids. So these are the normal layers of the retina. So as discussed by Dr. Anshika, so these are the normal layers of the retina. So Dr. Anshika has a special interest in the inner retinal layers. So what are the inner retinal layers which is important for the continuity of which of these layers is important for regarding the prognosis of the diabetic macular edema? Dr. Anshika, please.
If the involvement of inner retinal layers is there, like disorganization of the inner retinal layers, distortion, then that is indicative of poor prognosis, even after giving anti-VEGF.
And the outer retinal layers and the continuity of the outer retinal layers, which layers are important?
Also, we have to see the junction of this ellipsoid zone and external limiting membrane also. That is also important biomarker.
Very good. You very rightly pointed out the continuity of the ELM and the ellipsoid zone and even the inner retinal layers, that is the disorganization of the inner retinal layers. We will come to the disorganization of inner retinal layers, that is the DRIL in some time, in detail in some time. So, why the need of OCT biomarkers? So, why the OCT biomarkers are needed? Like any consultant, we know that if there is a cystoid macular edema, so that we can inject anti-VEGF. So, why the need of OCT biomarker? Why the special need for the biomarkers? हम लोग ये biomarkers क्यों कर रहे हैं, Dr. Bhavesh? Why are we deciding to OCT biomarker? Come this side, why are we short?
जैसे सिस्टिक मैक्युलर एडिमा में सिस्ट होती है तो जायंट सिस्ट हो तो उसका प्रोग्नोसिस पूरा होगा, वो फोटो इसको कंप्रेस करेंगे।
जैसे रेसिडियर टिश्यू होते हैं, रेसिडियर टिश्यू अच्छी है क्वालिटी में, उसका प्रोग्नोसिस शुरू होता है।
वेरी गुड डॉक्टर भाविक, जैसे कि डॉक्टर भाविक ने बोला कि जायंट सिस्ट है एंड प्लस हम लोग जो OCT बायोमार्कर्स हैं वी आर क्लासिफाइंग OCT बायोमार्कर्स because what happened in ETDRS study, they have found that 40% of patients they have responded to anti-VEGF therapy. They are a good predictors for anti-VEGF therapy. But 30 to 66% of patients, roughly around 50% of patients having cystoid macular edema will, even after giving anti-VEGF therapy, they did not respond much, their vision did not improve much. So, after anti-VEGF therapy. So the need for OCT biomarkers, so why they did not improve, should be switched to steroid or should be switched to a different anti-VEGF agent, or are there any, their prognosis is bad, visual prognosis is poor, so they need for OCT biomarkers for that. So, and one more thing that paradoxical visual acuity. Paradoxical visual acuity means we will see in day-to-day OVD many patients with center involving DME, which is called macular edema, but having vision of 6/6 parts or even 6/6. So, can anyone tell me which protocol states that the management for this kind of paradoxical visual acuity? Anyone? Any protocols are there? ETDRS protocol, S, D, U, V. So protocol B states that you can observe these patients. The patient having cystoid macular edema, having visual acuity of 6/6 or 6/6 parts, we can observe this patient, need not give anti-VEGF injection. The strict metabolic parameters, the control of the metabolic parameters is sufficient to resolve the macular edema. So this is the same thing that the non-responder pointed that 40 to 50% achieve significant visual gain, but 30 to 60% have persistent edema or suboptimal visual acuity. So are we justified in sticking to the anti-VEGF patient, but for our DME patients, so the need for biomarkers came into the picture. So now, what are the biomarkers? So, just can you elaborate like some of the biomarkers? What are the biomarkers? OCT biomarkers in diabetic macular edema. No problem. So first is the central subfield thickness. So the central subfield thickness is the diabetic macular edema on the central surface thickness. It indicates the macular edema in the central 1 millimeter zone. That is, the ETDRS have classified all the OCT softwares have this ETDRS circle within which 1, 3 and 6 millimeter are there. Okay, so the central 1 millimeter edema is there. Then the central surface thickness. So the more the central surface thickness, there are predictive response to the anti-VEGF therapy. So now in central surface thickness, as Dr. Bagrecha said, set as low size with giant cysts. So what happens in the giant cyst? It compresses the photoreceptor layer. So when it compresses the photoreceptor layer, so the visual prognosis decreases, and also the residual tissue. So Dr. Anchiko, what is the significance of the residual tissue between the giant cysts, between the outer and the inner retina? The residual cyst, the tissue should be more, less. What is the significance? Any idea or any distinct, like if the residual tissue is more, so and we give anti-VEGF, and in this like second picture, if the residual tissue is more, in the first picture the residual tissue is less. So what do you think? The prognosis will be better? We are giving ranibizumab in both the patients. So what is the prognosis? Which one has a better prognosis? The upper picture or the lower picture? First picture, why? Why? The edema is cystic in both the cases. Why not second? Okay, the second picture has a little larger cyst, but not much of a difference in the size of the cyst. But still the residual tissue, you can see the red point there in the first picture. So the red pointer in the first picture, it is the residual tissue. So compare the residual tissue in the below picture. The picture is not very clear, but you can compare the picture tissue, residual tissue in the second picture. The residual tissue is more in the second picture. Okay? So when there is a more residual tissue in the second picture, that is also an important biomarker. So the response to the anti-VEGF therapy will be better as compared to this. The response will be better in both the cases. But more the residual tissue, the more the probability and the chances of response will be better. So always look at the residual tissue as well. The size, the location and the number of cysts also matters. So this is the protocol we were talking about. So management of cyst involving DME with good vision. So it is an observation is a safe and effective strategy. Now what are the patterns of DME? So on OCT based classification, diabetic macular edema, there is spongiform, cystoid, neurosensory detachment and fractional DME. So suppose if a patient comes with let's say patients come with a spongiform macular edema with a moderate NPDR with a spongiform macular edema having a vision of 6/18. So how will you counsel that patient?
I will counsel that patient for metabolic control of diabetes first to get a metabolic control, and then I will explain him the need of anti-VEGF in this case, and I will explain that there will be a need of repeated injections as well at an interval of 1 month, and the vision can come after that, and we see the response, and then we again repeat the anti-VEGF if there will be need, and if it will resolve, then there will be no need, but he has to take care of the diabetes and he has to control his diabetes.
Very rightly pointed out by Dr. ma'am, that is a spongiform edema, and spongiform is a like of a diffuse macular edema. So the first thing is to follow strict glycemic control. Patients keep on asking us, कि डॉक्टर साहब मेरा तो शुगर कंट्रोल में है, मेरा फास्टिंग तो 90 चल रहा है ना, पोस्ट प्रांडियल तो 150 चल रहा है, फिर मेरा जो we cannot base it on one reading. The duration of diabetes is very important. Second, 3 months, HbA1c is also very important. So we cannot base it on one rating. And diabetic retinopathy mostly depends on the duration. Also, the type 1 and type 2, they have a different severity. And the cystoid macular edema, as mentioned, the size, location, and the number of cysts mentioned. Now comes the third picture, the serous macular detachment, also known as the neurosensory detachment. Neurosensory detachment is a good predictor. Anti-VEGF has a good response in this case of neurosensory detachment. But many recent studies have shown that neurosensory detachment have a high level of one cytokine. Can anyone name that cytokine? Starts with I. Very good. Very good. Interleukin 6. Interleukin 6 is a cytokine. So this neurosensory detachment, they are when they do not respond to anti-VEGF as a first line. So what we do is we wait for 2 anti-VEGF. Okay, we wait for 2 anti-VEGF, and the third line then we shift to the steroids. And what if the patient comes with like a fractional DME, like a D? So in D, it's a Vitreomacular interface abnormality. Okay, so Vitreomacular interface abnormality is causing the Vitreomacular traction and the fractional DME. So what will be your treatment of choice, ma'am, and how will you manage this case?
So initially, first the strict diabetic control we will ask the patient to control their diabetes, and then we can give the first injection of anti-VEGF to control the edema, and after that we will advise him for the surgery because there is a vitreomacular infection that cannot be treated by the only medical treatment.
Very rightly pointed out. So what happens in OPD? So what we do is, so suppose there is a fractional DME, and mostly in the cases of PDR with fractional diabetic macular edema. So what we do is we do a PRP, scatter PRP. So that like the other areas of fraction, we take 2 disc diameters away from that and we do a scatter PRP. We can give anti-VEGF 7 days prior to the surgery to reduce the risk of intra-op bleeding. So now the subretinal fluid. So what is the mechanism of subretinal fluid? It is associated with systemic urinary protein loss or hyperuremia, which leads to the increased hydrostatic pressure and accumulates in the submacular space. So now very important biomarker we will see in day-to-day OPD, hyperreflective foci versus hard exudates. So can anyone tell me, Dr. Anuj, so what are hyperreflective foci and what are hard exudates and what is the difference between them? I've made a table for this, but like in short, like how can we say on the OCT it is a hyperreflective foci or a hard exudate? Please have getting cold, please.
So hyperreflective foci are basically the precursors of hard exudate. Based on the size, we can tell that it's a hyperreflective foci. Hyperreflective foci are basically less than 30 micron, and hard exudates are more than 30 micron.
So very rightly pointed out by Dr. The size and the hard exudates, because of the size, higher, greater size, it will cast a back shadow, right? It will cast a back shadow, and hyperreflective foci, they are supposed to be the precursor of hard exudates and microglial. So now one more important point is if you keep a patient on regular follow-up, can anyone tell me that the severity of retinopathy progresses, what happens to the hyperreflective foci? Do they migrate or do they stay at the same place?
So after giving anti-VEGF, sometimes we see that the patient is not responding, the visual outcome is not responding. So this happens because the non-center, the para-center hard exudates, they migrate towards the center. That is why the visual outcome is not improving.
So that is because of the
Hard exudates.
What happens to the hyperreflective foci when the severity of retinopathy increases? Do they migrate or do they stay there?
So they stay there, they get, since they are the precursors of hard exudates, so they will convert into hard exudates ultimately.
Yeah, one pathway is that, and another thing is that as the severity of retinopathy increases, the hyperreflective foci they migrate from the outer to the inner retina. So that's why one biomarker, Anshika, we discussed before the class also regarding the choroid biomarker. What was that? Hyperreflective choroidal foci. So hyperreflective choroidal foci, why did they arise? Because as the severity of retinopathy increases, what happens is hyperreflective foci they migrate from the inner to the outer retina. So when they migrate from the inner to the outer retina, the prognosis is poor. So now the very famous, and it also happens in the vein occlusion. So what is DRIL? Anyone?
Organization of inner retinal layers. There is a, in the first picture, there is no disorganization of inner retinal layer because all the layers are in the same plane. Inner retinal layers, those inner plexiform, outer plexiform, and inner nuclear and the outer nuclear layers. But in the second picture, there is a in the this third picture, there is a continuity is lost in the center.
So we have to trace the GCL, INL and OPL complex, ganglion cell layer, intranuclear layer and outer plexiform layer. If these three layers, we have to trace, if these three layers are disorganized, means discontinuous. If we cannot trace this layer, that means the renal retinal layers are disorganized. So we could try with first anti-VEGF, but now the studies indicate which implant has been shown to ameliorate DRIL. Anyone? Which implant? Only one implant is there. Ozurdex has shown to improve the ameliorate DRIL. And now this is a very important. So the pearl necklace sign. So what is this pearl necklace sign and what does it indicate? Anyone? So you can see those hyperreflective foci surrounding the inner border of the cyst. So what are these hyperreflective foci? Again, they are a precursor of hard exudate. So it is an inflammatory biomarker. So when this type of cyst forms, it indicates chronicity. Okay, so it indicates chronicity. So it responds more towards steroids. So it is a kind of chronic exudated macular edema. So it indicates chronicity. So this is also an important biomarker which has given the name of pearl necklace sign. So Vitreomacular abnormalities we have known. So many patients will form this epiretinal membrane. So can anyone tell me that epiretinal membrane induces which kind of what it causes to the inner retinal layer? There is a separate term, technical term for the ERM causing distinct inner retinal layers, and they have a separate gradient for that, which starts the short form as EIFL. Anyone? So it is called ectopic inner foveal layers. So because of the anterior, posterior and tangential traction of the ERM on the inner retinal layers, it causes the ectopic inner foveal layers. So the inner foveal layers they are a little elevated, and this ectopia happens. So there are a rate of grade 1 to 4 for ectopic inner foveal layers, and the grade is basically regarding the prognosis, which responds better to the vitrectomy, which responds better to the ERM. And as we know, BMA, BMT we discussed. BMA is just an addition. So BMA we can observe. For BMT it responds better to vitrectomy. So now this is the ellipsoid zone, ELM zone. Continuity is very important. Ellipsoid zone disruption, ELM zone disruption is there, so it indicates a poor prognosis. So one more thing we forgot. So anyone can tell what are bridging retinal processes?
So bridging processes are present between the cystic spaces. So these are indicative of good prognosis. Since these processes, they are helping to transmit the visual signals. So it has a good prognosis. If they are absent, then the visual outcome will be not that good.
What are these bridging retinal processes?
So basically, they are the connections of the inner retina to the outer retina.
The remnants of ametrine and Muller cells basically. So when these connections are there, so as Dr. Anshika said, so they transmit the impulse from your outer to the inner retina. So they have a good prognosis. So the residual tissue, as we pointed out, pearl necklace sign, the DRIL, ameliorate steroids, hyperreflective foci. So in practical scenario, suppose if a young faking patient, we had a 18-year-old type 1 diabetic mellitus with a mild NPDR with center involving diabetic macular edema with a hard exudate around it. So the vision was 6 by 18. So 18-year-old faking patient, mild NPDR with DME, cardiac surveillance, type 1 diabetes mellitus. So how will you approach? The first is with glycemic control. We did an OCT, it was strictly involving diabetic macular edema. So Ritika ma'am, how will you counsel this patient?
So first of all, we should have a good control of diabetes, and then he's having diabetic macular edema. So we'll go for anti-VEGF first, and then we'll see the response to that anti-VEGF injection. If it resolves, then it's good. If it doesn't resolve, then we can go for steroids implant in this patient. And then if it resolves good, not, then we'll go for FFA, then we'll do PRP in the subsequent sittings. If we feel like that it is it's anti-DRP, then there will be no need of PRP as such. But in future, if it develops to PDR, then we will need PRP. So we will counsel the patient regarding the whole journey in this.
So very nicely pointed out. So my question is if they are given anti-VEGF, so clear lens young patient will be first treatment name patient. The first choice will be an anti-VEGF. We can give a bouquet of choices of bevacizumab, ranibizumab, and even aflibercept. So first choice will be an anti-VEGF. So after 2 anti-VEGF injections, we generally shift to steroids, intraretinal steroid, either intraretinal transdermal or an orthotics implant after 2 anti-VEGF injections. Some people, some consultants, they even they mix anti-VEGF plus intraretinal transdermal, 0.05 intraretinal anti-VEGF with 0.05 intraretinal transdermal. They do that also. It was basically in cases of PDR. So after 2 anti-VEGF, we shift to steroid because young patients now, so the risk of cataract formation is there with intraretinal anti-VEGF steroids, and the risk of higher IOP is also there. So these are the hyperreflective choroidal foci which migrates the hyperreflective foci to the choroid and it indicates poor prognosis. And we discussed the ELM and the EZ depression. So coming back to our table, so in a nutshell, so what are the good biomarkers and what are the biomarkers which indicates poor prognosis? Anyone good biomarker? One. Good biomarker.
That bridging retinal processes, factors of field thickness, spongiformity.
Dr. Nipun good biomarker. Say from there on we are going to understand. I'll tell you back. I'll give it to you. Hyperreflective. Yeah. Bad. Poor prognosis. ये आपने यहाँ पे बोला था. Yes, giant ophthalmological cysts is a bad biomarker. And one bad biomarker we forgot. One very important, very famous. Bad. Very good. Yes, very good. And one biomarker, I forgot I included in the slide, but somehow the slide was missed. We discussed also. No. Yes. Parallelism. What is parallelism? Anyone?
All the layers are in a parallel form. Inner retinal layers. Or outer is also in the parallel layer. So when there is a disruption, so those parallelism is lost.
Actually the outer retinal layers are subfoveally. The ELM, the ellipsoid zone, and the external limiting memory, the ellipsoid zone, and this thing, RP. So these three they have a software that skeletonizes these layers. If things are parallel, then they indicates a good response to therapy. If this parallelism is lost, it indicates bad response to therapy. So all said and done, so these were the biomarkers, and all said and done, diabetic macular edema is the most common but most difficult to treat. Sometimes the diabetic macular edema will have to monitor to such an extent that it is a recalcitrant diabetic macular edema. So when there is a recalcitrant diabetic macular edema, the vision goes to a level of suppose say 6 by 12, 6 by 9. So whatever you do, you given ozotexin plant, you given this thing with anti-VEGF, you can try bevacizumab, faricimab, whatever you do, sometimes the vision stays at a level of 6 by 12 to 6 by 9. So at that point, no point in giving further anti-VEGF agent, just take metabolic control and observe the patient. And in India, as we said, first 3 loading doses, and then pre-skin regimen is possible in the Western countries, but in India, we have to follow the regimen of first 3 loading doses and then monitor and extend. So that was about the OCT biomarkers, and I hope you learned something. Thank you. And